Hello, everyone. I'm Dr. Carmen Puliafito, and I have here with me today Dr. Michael Klufas of the Wills Eye Hospital. Michael, welcome to Retina Synthesis.
Great. Thanks for having me. It's a great program and glad to be on it and really enjoyed the other episodes I've seen over time.
So, at the Macula 2026 meeting in Philadelphia, you presented results, first time results from the Belvedere trial of the port delivery system implant for neovascular AMD. And this was a study in eyes that had high injection burden. Can you tell us about the Belvedere trial?
Yeah, absolutely. So, as many may know, there were many phase three registry trials, mostly Archway for neovascular AMD. Then we had Pagoda for diabetic macular edema, and then Pavilion for just diabetic retinopathy. Those were the phase three registry that led to approval. And so, Belvedere is actually a phase four study that was looking to enroll about 200 patients, and this was an interim analysis. But really, the impetus was to look at patients who were treated with other agents aside from ranibizumab, primarily off-label bevacizumab and aflibercept, which has been, a dominant intravitreal anti-VEGF over the past decade, and see how they did when they switched to the port delivery system, commercially known as Susvimo. Um, Patients had to have at least two intravitreal injections. And an important criteria too was about half of the patients, at least in this interim analysis, had a very high treatment burden requiring injections of nine or 10 or more in a given year, and to see how they might do with continuous anti-VEGF therapy with the port delivery system.
So, on average, what were the number of injections that these patients had on an annual basis?
Yeah, absolutely. The high treatment burden patients were defined as those who had greater than nine injections in the preceding 12-month period. If they hadn't been followed for that long or data was not available, that was obviously extrapolated out. But yes, the high treatment burden ones were nine or more injections in a year. So you're on average looking at 6 weeks or higher treatment burden. Of course, there were ones who received 12, some who received 10, some who received nine in a given year.
How many eyes were in the study?
Yeah, so this was interim analysis. So the way the data broke down is for safety, there were 93 eyes that were included in this data cut. And then with regard to efficacy, it was 84. Why is it slightly less? They wanted to go through two refill exchanges to have adequate data. So if they had not received a refill exchange or discontinued the study, they would have not been included in this analysis. And then the number of high treatment burden patients which is an annualized rate greater than nine injections per year, was 43 in this particular analysis.
What was the length of follow-up?
Yeah, absolutely. Follow-up time was approximately 56 and 66 weeks. The primary endpoint is actually 48 weeks in the study. So if we look at those who completed 48 weeks, you have pretty good visual acuity data over that time.
So, what was the visual acuity data like?
Yeah, so these patients had pretty good vision. Looking at the change over the 48 weeks, if you looked at all comers, which were 84 eyes, there was like a loss of 1.1 letters over the 48 weeks. And then if you looked at the high treatment burden patients, there was a loss of 1.2 letters. If we look at the baseline ETDRS letter score, it was about 73. So this is around like 20/40 Snellen equivalent. So I think what's interesting too is a lot of these patients have driving vision or better for activities of daily living, and they're undergoing a surgical implant, with different risks and benefits to intravitreal injections. But generally like good seeing eyes. These are not 2200 eyes or 2080 eyes even. Like on average, they were 20/40 or better.
What was the frequency of supplemental injections?
Yeah, absolutely. So if we look at lower treatment burden patients, these were patients who had less than nine injections a year. None of these patients required supplemental therapy. And there was a pretty good swim lanes presented during the talk. if we look at the high treatment burden patients, which was a swim lane of about 30 patients presented during the talk, there was only one that required supplemental therapy. And this is obviously a clinical trial, so delve back in with Genentech Roche a little more detail why that supplemental therapy was needed. Um, there was a decrease in vision of like greater than 10 letters, and OCT was equivocal in terms of increased thickness. It was like 20 microns more. So at investigator discretion and with the monitors, they decided to treat this patient, but there actually wasn't visual improvement after the supplemental therapy. They went on to receive phaco, 6 or 9 months later, and then the vision actually improved. So there wasn't evidence of subretinal hemorrhage. That was my first question. Like, is there a breakthrough bleed or, a large increase in CST? There was definitely a decrease in vision that justified the supplemental therapy, but it was actually thought to be mostly due to cataract progression in that particular patient. And, having done a fair amount of these, usually you're not like hitting the lens or causing a PSC or anything like that, but they're older population and cataract after surgeries. A lot of us give dexamethasone or Subtenon's catalog at the end of the case can definitely cause progression of cataract. So I'm actually not surprised to see that, but I would err on the side of caution of treating, potential exudation or vision loss in these patients as well. So I think the investigator in the trial monitors did the right thing.
Well, it is an extraordinary result. Only one supplemental injection in 84 eyes over 48 months,
Weeks, 48 weeks.
weeks, 48 weeks, excuse me. It's extraordinary.
Yeah, I mean, I think that most of our patients, you definitely have patients like in the clinic who, someone's like, hey, you can go 6 weeks, but they're like, oh, I really prefer 5. I start noticing at 5 weeks and one day when there's like some early subretinal fluid or exudation developing. And a lot of us look at the port delivery system. The control groups are monthly intravitreal injections, and we're trying to mimic that. But with continuous therapy, it's actually, I think a little bit different. I don't look at it as an intravitreal injection because, yes, it is ranibizumab, it's concentrated, but you're getting that sort of little drip out. And like one commercial patient I treated recently, and I learned this a little bit from gene therapy trials. She always had fluid at about 4 weeks on aflibercept 2 milligrams. So then I tried faricimab, and she still had fluid at 4 weeks. And then I said, okay, let me give you a faricimab and see you in 2 weeks. And there was less fluid, but there was still exudation. Ultimately, we discussed, should we go forward with continuous therapy and placed Susvimo, and she's dry, and she needs refill at like 5.5, 6 months. But that's the only time I've seen her dry. And it's sort of like the best analogy I say is, like when steroids wear off, whether it's like, post-cataract CME or chronic uveitis, whether it's Ozurdex, or or Utique or any kind of intravitreal steroid, they have, when it wears off, the edema comes back. But I think a similar case can be said for Susvimo or port delivery system. When you get that continuous drip, some of these eyes just have a high VEGF burden. And when you have that little bit coming out over time, it controls the exudation. And if you look at some other analyses that weren't presented in my talk, but especially patients with persistent fluid from the registry trials, there is data to suggest that there's a trend towards better visual acuity in these patients with persistent fluid, even at 4-week intravitreal injections. So I think that's a really interesting subset to look at. And discussing with some of my partners, some of them are like not like tail end of career, but they're not really interested in integrating a new surgical procedure, but they may have these Q2-week intravitreal injection patients, and they're like, this might be a really good option because Q2-week injections not only massive burden to the patient, but also billing problems. What are you going to use at that 14-day visit, sample or off-label bevacizumab? And so I'm really interested in integrating it more in these high treatment burden patients in my practice if they're not happy with monthly injections.
What was the patient satisfaction? Was there an objective measurement of that?
Not in the analysis I presented. I'm not sure in Belvedere if they're repeating those patient questionnaires. Dr. Margaret Chang has definitely done a lot of research on this. And, if you look at Pagoda for diabetic macular edema, which was the phase 3 registry for DME and PDS, and then also Archway, which was the phase 3 registry for PDS and neovascular AMD. In AMD, these patients typically have had a lot of prior treatment, multi-years sometimes before entering the trial, and their satisfaction is usually stated 93% or higher preference. In the DME trials, it's a little lower, closer to 80%. They haven't had injections that long. They usually get a loading of, 3 to 4 injections or a side to injections for the first year and then cross over to the port. So I think that's interesting, different age populations, but also different experience with intravitreal injections. I think, being in the patient seat, I've never had an injection. I've had betadine in my eye once. That was bad enough. But, they get multi-years of injections and they always remember, obviously, the time they had a corneal abrasion or, didn't like the betadine or want it rinsed or a specific way and feeling tired afterwards. So these are all these things I like to take into account, seeing the clinical trial data and potentially using this treatment in my practice.
So what are your patient selection criteria and how frequently are you using this in your practice?
Yeah, it's been so interesting. I think it's just amazing that you see this device has kind of definitely come with major strides over the past 10 years, especially with regard to surgical technique, which is constantly evolving. Um, but for instance, like maybe 2 months ago, I had another commercial for diabetic macular edema, and I had my fellow put one in. He's going to practice in Maine. He did it. He did the procedure. So I've kind of seen it full circle. And Carl Gilla had involved me in some of the clinical trial programs earlier on. So it's kind of nice to see trainees now being exposed to this and potentially offering it in their practice. But with regard to when I'm offering it to patients, obviously patients who are dissatisfied with intravitreal injections, there's patients who have anxiety. There's patients who just need like a benzodiazepine sometimes before an injection. It's very rare. There's obviously things you can do to try to comfort them or modify the process to make it as comfortable as possible. But these patients who just like are fearful or don't like intravitreal injections, even if they're at a 10-week interval, I'll definitely bring it up as an option. What's interesting is there's not a lot of direct or any direct to patient advertising for this device. So it really has to be a clinician initiated conversation. There are some direct to patient radio ads that I think are being done by Genentech Roche on Susvimo, but in general, it's got to be brought up by the physician. But, we do know that this is a permanent implant in most cases. So if the conjunctiva is not healthy, I always assess that first. And what I like to do is just place a drop of proparacaine and a cotton tip with a little proparacaine, and I'll actually go to the slit lamp, narrow beam, and move the conj. And if it's highly thin or there's like a large plaque in the area when I'll put the implant, or if there's like a high risk of needing tube, like these are not ideal candidates. I think whenever you're trying to integrate something into your practice, you obviously want to have success. But if we know the conj is not healthy, this leads to retraction and erosion, and that obviously can be a risk factor for endophthalmitis. That being said, I've revised some of these that have needed like conjunctival procedures, and it's a lot easier than any retina surgery. So you can definitely usually salvage the implant, and it's very rare to need to place like a semilunar corneal graft, etc. But I always like to look at the conj first, because if the conj is not healthy, I always worry maybe the first year is going to be okay, but like what happens over 2, 3, 4, 5 years, and that's always a consideration. Um, so healthy conj, also patients who are dissatisfied, and then the high treatment burden patients. I mean, I don't know a single one who's getting like whether it's 2, 3, or 4 week injections who's entirely satisfied. Especially with like some geographic atrophy treatments now available. That's like a high treatment burden. They're sort of going back to monthly. If you're not doing the anti-complement and anti-VEGF same day, usually they're able to get them out to 8 weeks on the anti-VEGF and then 8 weeks on the anti-complement, but they're coming in every month. And while the older population is quite compliant, it's just a very high treatment burden. I'm not necessarily placing this device just so I can administer anti-complement therapy, but that all factors into the milieu if it's the right thing. Diabetics, I haven't really figured it out quite yet. My biggest qualm is, you got, say, even a 50-year-old diabetic, like there is a very long lifespan for this patient, and this implant should be intended at least to last, a decade or longer or the rest of their life. And so whenever I'm implanting one of these in that patient population, I just really think about the future and is this going to last the whole patient's life? Their conj is usually quite healthy, but it's hard to predict, 5, 10, 15, 20 years in the future for those patients. And some of those patients switch insurances. I've definitely had carriers that say, look, like this patient got this device, but we want you to revert to intravitreal injections. And that's always dissatisfactory. So you got to consider all these different things for the patient long term. But we know compliance is an issue in diabetics too. So I'm still navigating that population and how I should best integrate it for DME and sometimes maybe DR. I think DR is something we'll look at more in the future once we see like very good results with diabetic macular edema.
How difficult is it to do the refill exchange?
You definitely want to have magnification. It's not hard to do the refill exchange. Nothing is super difficult for us as retina surgeons. Like the surgery is straightforward. Revisions are not like PVR detachment or anything like that. These are quick surgeries. But refill exchange, I've never done it without a speculum. You really probably want a speculum in general, because you want to like sort of retropulse the eye with a Q-tip and then have very precise targeting. But the septum is quite small. Under an operating scope or a slit lamp, you would see that needle go in there perfectly. But if you're going to use a traditional injection technique, standing up, having a patient look down to the nasal side, you do need a little bit of mag. Otherwise, it's difficult to see. Um, Sometimes there can be like conjunctival blebs that form over these. I've refilled them through that. I haven't had a lot of trouble, but sometimes there can even be like a tenons that grows over and the actual implant can be harder to see. And these implants, it's like a buckle. They develop a fibrovascular capsule. So if you ever have to remove them or put another one in, you see that capsule, and sometimes that can create some opacity. It's rare. But you need to be precisely targeted. There's some wiggle room, but it's a little different than intravitreal injection. Not necessarily harder, but riding a bike, you want to be able to do it a couple times and then it becomes quite smooth. The other thing that's different about the refill exchange is, earlier on, the incisions used to be 3.7. Now they've been recommended like 3.3, 3.4, 3.5, no larger than 3.5 after you've ablated the choroid with laser, et cetera. And that can sometimes change the size of the incision. So there were some implants that you could even get dislocation into the vitreous cavity. That's very rare now with the smaller incision size, but I bring it up because in the beginning when I was refilling these things, I didn't want to put too much pressure. I was like, gosh, like this could dislocate in if you're really pushing quite hard. But there's that capsule, so there's some resistance. So it's like different than going through the scleral fibers. So you just gotta take all these things into account when you're doing it. But usually they recommend a headlamp with magnifying loops. You get it on Amazon for 15, $20, and that's plenty of mag to allow you to see it and position everything properly.
So that's what you use?
Yeah, yeah. The clinical trials, they provided it as we had some trial patients actually coming out and commercial ones. It wasn't provided by Genentech Roche. So it's like $18 on Amazon. It comes with zero point 0.5, 1, 1.5, and 3 magnifiers, and it has just two AAA batteries, and it works really well. If you have multiple offices like us, wherever we offer the exchanges, which is pretty much everywhere, we purchase them, but it wasn't a large cost burden and easily replaceable, if
How
not
much is
there.
the exchange refill?
Uh, So it's comparable. I actually don't know the exact pricing of it. Uh, it's comparable to now the price of Lucentis is quite low right now. I think it's around 380 to $400. And a biosimilar known as Cimerli has also been reintroduced to the market at a price of 200. While I don't know the exact like wholesale acquisition cost of the refill exchange, I believe it's quite similar to receiving monthly 6 monthly Lucentis
Mhm.
intravitreal injections, or quite close to that.
Is the reimbursement able to be achieved?
Uh, for implantation and refills.
Yes.
Yeah, the what's very interesting is with regard to the actual surgical procedure. say a patient has a very large co-insurance, Genentech Roche offers a very good assistance program, which I think is something up to $10,000 to $15,000 for those fees. So I would say as long as it's on the medical policy of the carrier, it's pretty easy to get approval. I've seen one carrier who just didn't place it on their medical policy, and then it's quite difficult to get approval for the procedure. Even talking to a medical director, if they don't place it on the policy, it's quite difficult. But the same goes true for if you want to use aflibercept 8 milligrams. If it's not on their medical policy, you're not going to move very far until they add it. So I've definitely seen that in some carriers, but it seems to be more and more common that it is on the medical policy as they have more requests from physicians and patients. And then once if the implant's been approved, then usually the refill exchange is approved as well. If the carrier doesn't have, the ranibizumab 100 milligrams per ml on their policy, there is also a patient assistance program. So long as their income is not too high, you can get the refill medication from Genentech Roche as well.
If if a surgeon wants to start doing PDS, does Genentech offer a training program?
Yeah, that's very, very excellent. They have something called a surgical device liaison or surgical device specialist, SDL or SDS. And many of these are, everyone I've encountered is excellent. I had them with me for the clinical trial. There was a certification for this. So while you're welcome to go, jump in the water quickly, you can definitely have the SDL come with you for as many cases. They will come for as long as you want to the operating room with you and guide you through all the steps. And there's a VR simulator. There's also a very large library on a website that they have, so you can see like some of the pearls, such as like repositioning the conjunctiva properly using, non-tooth forceps to eliminate buttonholes, like dissecting the conjunctiva back so it can be approximated to the limbus, or even a little further, expecting retraction. So they've learned about a lot of these things. Probably the biggest one is the conjunctiva. I think, the head of the program at Genentech was actually a glaucoma surgeon who trained at Wills. So she was like, why are all the retina surgeons using 0.12 forceps with the conjunctiva? Like, when do you do tubes? We never use this. So they've made these little advances. They've shortened the incision size to 3.5 versus 3.7. There was some vitreous hemorrhage early on, things like the Incelto implant, they don't recommend ablating the choroid, but for like port delivery system, they recommend ablating the choroid with, an endo laser, whatever gauge you want, prior to actually placing the device. And that's reduced vitreous hemorrhage from rates of like 20% down to, less than 3 to 5%. So they've learned a lot over time. They're investigating other things such as like a diode laser instead of, an argon laser to ablate the choroid as well, may lead to less atrophy at the edge of the incision. So all these pearls have come into the instructions for use, and I would suggest surgeons follow those instructions for use to start, because there's usually a reason behind all them. And I think if you're trying a new surgical procedure, all you need is like a complication to start, and then you're probably not going to do it again. So, patient selection, but then following the instructions for use are probably pretty paramount in my mind, at least when you're starting out. And then you can have little tweaks to the procedure as you go on if you wish.
Well, what else should our audience know about Sysvimo?
Um, let's see. So right now it's the only on the label indication you have to receive just two anti-VEGF, sort of to demonstrate a response to anti-VEGF, and then the device can be placed for neovascular AMD, diabetic macular edema, or just DR as well. The recommended refills is every 6 months or 24 weeks. I've never tried or had to refill one of these before 6 months, but given that's the label, I probably wouldn't recommend doing that, especially reimbursement, et cetera, at this time. You are able to administer a supplemental therapy, just a standard intravitreal injection with the implant in place, if you wish, or there's a need for supplemental therapy. Although, as you saw from the data from Belvedere, the rate of supplemental therapy is quite low. And then for diabetic retinopathy, the recommended refill exchange is 9 months. Now, why did they choose 6 months? It's sort of like treating the whole herd of the population. they knew they could encompass 95 to 97% of treatment burden with Q 6 month refills for these major retinal vascular diseases. But if you go to Ladder, which was one of the phase 2 trials, many patients were able to go 9, 10, even 12 months without a refill. So while I'm not doing that too much in my practice, just because a lot of these cases are unilateral, want to monitor the fellow eye, many of these patients may be able to go longer than the recommended 6 month refill. So that's another sort of thing I think we'll learn from real world use. Um, and yeah, I think the other thing is some of the complications, conjunctival retraction, erosion, they had a problem with the device that led to a voluntary recall. So the device is sort of a rigid polymer, and then it has the septum that allows the refill exchange. And there was a problem with the bonding. And so this was during the clinical trial period. So they did a voluntary recall, and we had to remove a lot of these devices and place the new ones with a better bond. And that's even an easier surgery, actually. Like, so, however long it takes you to start, like if you ever have to like remove and exchange one of these eyes do like amazingly well. And I was interested in looking at that as well. So these eyes that underwent secondary operations, I looked at those with Genentech, and we presented that at Vail this year. And they do great, like 98% maintain vision, 20/40 or better. Even in cases of endophthalmitis, the implant doesn't always have to come out. The implant can be irrigated with vancomycin with the refill exchange needle. So I would say, if you do surgery, you're going to expect complications. Like nothing's going to be 100%. It's just like retinal detachment repair, or, if you're going to do a 20/25 pucker, like there's risk of RD, there's risk of endophthalmitis. So all these things, are manageable. And I would say a lot of the complications are not as severe as some of the retina surgery complications we deal with, like PVR or, RDs even. Like they do really well with the reoperation. And then, of all the reoperations I've done, which are not tons, but enough, I've never had to not be able to place a new device. And the patients are really tied to this device. Like I had a 9-year-old guy, he had one and he had a septum dislodgement, and, talked to him about the surgery. I was like, we could go put another one. And he's like, please put another one if you can. I don't want to go back to injections. And we were able to do that. He did great. Even in our practice from the trials, we had one complete dislocation into the vitreous cavity, and I didn't perform that surgery. My colleague Jason Shu did, and he was able to place another device, and patient was really happy, and there was no like adverse events afterwards. So I've been very interested in seeing what happens with these devices that need more procedures, and the outcomes are really, really good, which is encouraging as well.
For the right patient, this seems to be an excellent opportunity.
Yeah. And I think we have to do a better job of learning who the best patients are. And I think those frequent treaters are a place where we can make some progress. And, another piece of data we didn't mention, aside from the trend in better vision with continuous anti-VEGF therapy, there was this decade-long discussion on the circuit podium that like increased anti-VEGF treatment led to atrophy, but they're actually seeing with continuous anti-VEGF that the rate of atrophy may be lower too. We know GA is a large problem for this patient population, so perhaps continuous therapy may have some effect on geographic atrophy or slower rates of geographic atrophy compared to discontinuous anti-VEGF therapy.
Michael, thanks for joining us on Retina Synthesis and sharing your observations on the port delivery system.
Thanks so much for having me.